Thank you very much, and good morning to everyone. So I'll talk a little bit about fistulas, and then come back to whether we should get them or not at the end. I'll start with this one. So kidney replacement therapy in the UK, essentially the modality used at the start of kidney replacement therapy in our pediatric patients, according to the renal registry, and this is children below the age of 16, is shown here. And you can see hemodialysis is something like 34%, and the total number of patients here is about just over 800 that we're talking about. So transplantation is a smaller part of this cohort. And of course, once transplanted, the figure varies from paper to paper, but 25 to 39% of children return to dialysis before moving to the adult program. And indeed, Zainab mentioned this yesterday in her talk as well. So this is how hemodialysis life looks like. And the next thing I wanted to mention is this consensus document by the European Society of Pediatric Nephrology, dialysis working group. And Roxana is a professor at Gradomo Street, and Francis Carter was the one who was meant to give this talk, just to give you an idea. So what does it say? It talks about education, which is very important, as we all know. Education of the child, education of the carers, education about preservation of the veins, because we're all obviously all know that we need to preserve them for life. And then also talk to them about the options of renal replacement therapy, including transplantation, peritoneal dialysis, indeed home hemodialysis and in-center hemodialysis. And it suggests referring the child early to a dedicated vascular access clinic. We will see these repeatedly, where the anticubical vessels are used for needling, unfortunately. And we need to make sure that we preserve them as much as possible. And every hospital has its own way of trying to raise awareness and give the child empower the child to protect my veins, as well as the family. And we all know that the back of the hand should be used for taking blood samples. Now, Francis and the group started a one-stop dialysis, as a one-stop access clinic. And this was at the GOS and of course at Avellina as well. And this was about, it was about 2014, I think. Anyway, and after the first 2 years, they wrote their experience, and I'll show that further down. But essentially, when they come to clinic, obviously we need to assess the veins, the arteries, and make sure the heart or the pump is good, as well as the skin. And we need to make sure we do this the right way. We need to settle the child, make sure that they're comfortable, relaxed as much as possible, and obviously use a tourniquet of some sort to assess the veins. Of course, some children will need a bit more than that, a bit of psychological preparation to come to terms with respect to using a dialysis machine. Now, what we tend to say is if the child is pre-dialysis and has a live donor, a potential live donor for transplantation. Oh, okay. Thank you. Can you hear me now? We should aim for a preemptive transplant. With respect to cases where there's no live donor, we should advocate an AVF. If they're on hemodialysis by a line and there's no live donor transplant, again, we should advocate for an AVF. If there is a live donor transplant and that's planned soon afterwards, we should keep the dialysis line, as it would take much longer to prepare for the fistula, of course. Now, every assessment is not equal. Some children may have other issues. You can see here the dilated veins across the chest, and they may need further investigation before deciding what kind of access to provide. Now, going back to this paper from Francis, just to give you an idea about numbers and fistulas. So in this particular 2-year follow-up after the start of this one-stop clinic, was a provision of radiology as well. There were 12 new fistulas and 11 pre-existing fistulas. And you can see they varied from brachiocephalic, radiocephalic, or basilic vein transposition. So all fistulas were provided, were offered, let's say. And this is a typical result following an ultrasonic angiology review. So we have a radiologist that comes from Guy's Hospital and goes to Great Ormond Street as well as to Evelina to assess the veins for us, and they do a thorough scan, including all the veins and all the arteries. And essentially, what is an adequate vessel? In this review, a maximum median diameter of 3 for the vein was showing, and as well as an artery, a maximum median diameter of 2.7 showed a primary maturation rate of 82%. Obviously, the bigger the vessels, the easier it will be to do, and the chances will be better. Now, we generally advocate not to ligate the fistulas, because obviously the child will have a much, we hope, a much longer life ahead, and therefore every vein every fistula that's divided and cannot be used again, of course, and we don't want them to run out of access in their lifetime. And I'll come to this point a little bit later on, because obviously not everything is 100%. So fistulas can be used after transplantation as well. We tend to use them to take blood, as you can see here. And the child on the left, he was 18 months old when I did his left radiocephalic fistula, you can see here. That was from Gauche, and another one I did at Evelina. So those were the smallest ones I've ever done. And I can tell you, it's difficult to see the vessels. Now, going back to the consensus, it says we need to use the lines for dialysis for small children, and doesn't specify the size, but because of the small vessels, because of the surgical expertise to create the fistulas, also because of children needing dialysis more urgently than waiting for a fistula. Sometimes the patient and the family more frequently will advocate what we should do. Also, it may be necessary to dialyze before transplantation, and therefore we'll need to use those lines. So this is what this paper says. Also, for evaluation, it does talk about duplex ultrasound, but also when necessary, venography, CT, or MR, especially in those cases where there's central stenosis. And this is where we should do the fistula. As in the adults, we should use the non-dominant arm and place the fistula as distally as possible, depending on the vessels, of course. And of course, we see them in clinic, usually around 6 weeks, to assess the flow, again by duplex. Surveillance, that varies wherever you go, but you can use, again, a duplex scan. Usually we see them, it depends, of course. We can see them ad hoc, but usually every 3 to 6 months. And we tend to do an ultrasound scan as well. They can have a transonic during the dialysis once a month as well to assess. And if the flow is reduced by 25%, they send them to our clinic. We tend to give aspirin, definitely for a few months, as there's some evidence that helps with the patency. Now, this is an interesting paper from the States this time, and it talks similarly in when to use the dialysis lines for kids and when to use a fistula. So indications for tunnel line, similar to the previous paper. If the AVF is created but the child does need dialysis in the meantime, the AVF is not ready, if the PD has failed or the transplant has failed, or if there's a pending living donor transplant, it says within 90 days. But that could be a bit more, of course. Longer term indications, multiple phase fistulas, but also transplantation within 6 to 12 months. And with respect to the fistulas, it says the indications are for children over 20 kilograms and not expected to be transplanted within 6 to 12 months. And yeah, the same paper talks about having an artery of at least more than 2 millimeters and a vein of more than 2.5 millimeters. And usually when you do this fistula in the kids, usually the vein is okay. Most of the time is the artery that's a bit smaller, sort of the inflow. And therefore you have to compensate by doing a slightly bigger anastomosis to increase the flow. And following on to this, yeah, it's from adult work, of course, how many fistulas are ligated going forward. So this is paper from Doris Sayev and in Baltimore. So it talks about the practice patterns in fistula ligation among kidney transplant recipients in the whole of the United States. And it's got more than 16,000 patients with functioning fistulas or grafts that had received a kidney transplant between the period of 2011 and 2013. And this paper was published in 2019. And 4.6% underwent post-transplant AVF ligation. And yeah, the figure on the right shows the incidence of ligation, and essentially 4% at 2 years and 9.3% at 3 years. And of course, there's a lot of center variation with respect to who does fistula ligation, from a number of centers that do none, and some centers doing more than 20%. And this Kaplan-Meier curve shows the 3-year graft survival to be 4.9% versus 9.5% of kidney transplant recipients who did not undergo ligation. So essentially, and that was not significantly different. So no difference with respect to graft failure in the two groups. And this is the only paper I could find where there was a randomized trial whether to ligate a fistula or not. Again, it was in adults more than 18 years old. So in summary, 27 cases in each group, and they were ligated or not ligated. And you can see here the measurement of, it was a baseline cardiac MRI, as well as one at 6 months. And the left ventricular mass, as you can see here, the control on the left and the AVF ligation on the right is reduced after the ligation. And the same for the scan, for the second scan. Sorry, I'm getting confused. So the first one is the left ventricular mass, and the second one is the left ventricular mass index. And we've got the control on AVF and scan 1 and scan 2 for each one. So in scan 2, after the IVF ligation, there is a significant reduction in both the left ventricular mass and index. And also the same can be seen for the anti-BNP. There's a reduction in the ligation cohort. So this paper talks about these encouraging results with respect to potential management of cardiovascular risk long-term, and tries to hint towards ligating fistulas when possible, also because it's a small procedure, local anesthetic most of the time. And that's it. I'd like to thank Francis for some of the slides. Thanks.
Great. Do we have any questions?
I've got a question. What do you do in your centers? If you can tell us about, first of all, do you do fistulas? And if yes, what age or weight? Just to get a broader sort of picture of what's going on. Oops. Yeah.
No, that was me, I think.
Apologies.
Went too close to the...
It'd be interesting to know what happens in other hospitals. What do you do in Leeds? No kids. No kids with a fistula, yeah. Yeah. A lot of PD, yeah. Helsinki? Where's Kaisa? Oh, yeah. You're not sure, but probably none? Yeah. Oh, wow. And they get transplanted very soon afterwards. That's excellent, yeah. No, that's great. Seattle?
So we have started to use the ellipsis device
Oh, yeah. Excellent.
for the older adolescents, which are interventional radiologist places.
Yeah.
And we've had some success with that. But otherwise, most of our kids have catheters. Yeah. We've had trouble finding a surgeon, even amongst our pediatric surgeons at the hospital who can actually do fistulas in the young kids.
Yeah, I mean, we used the lips as well. We only did about 3-4 cases, but for adults. And even though the results seem to be better in different hospitals, the flows were not always good for adequate dialysis.
Yeah, they can be a little deep, which is the other issue. So you have to use ultrasound guidance to access them. But they work very well in our hands.
Good to hear. Okay. Yeah, in our adult program, we wait for 1 year, have good stable function, and then if the patient wants to, we ligate it. Yeah, a bit less reluctant in kids, and but we do keep an eye on them in clinic even after transplantation for the fistula point of view. We had, from memory, the last few years, we only had one that had a high outflow fistula, and actually I tried to reduce its inflow by 50%, but still had high flow, unfortunately, and tachycardia, and we ligated that one.
Yeah, I thought the data on LV mass was very interesting in that study.
Yeah, there's not a lot. I mean, we should do more on that, definitely. An area to explore.
Well, room for a study, right?
Yeah.